we invite you to say your name and your organization and where are you coming from? Where are you located? Thank you. We always have our audience from many places around the world, so it's great. DRC, Malawi, Nigeria. That's great. So thank you, everyone. Continue introducing yourselves, and we are going to start by introducing our panelists. I am Anabela Sanchez, and I will be your facilitator today. Next slide, please. And this education series, we usually co-facilitated with my colleague Nora, but she had a last minute activity, so she's not joining us today. Thank you, and we are looking forward for the great meeting. Quantification forecasting is always a crucial activity in as part of the supply chain management. Next slide, please. We are also honored to have our speakers, Laila, Danielle Jurman, and Wadhah. So please, I will let Laila introduce herself. Please. Thank you for joining.
Thank you, Anabela. I'm a pharmacist with over 20-some years of now experience working in the development setting mostly, just briefly in the humanitarian, which we'll review today. And have mostly been focused on forecasting and supply planning in the past across multiple different pharmaceutical commodities and products. Thank you so much.
Thank you, Laila. We are very honored to have you with us today. And next, Wadhah, please introduce yourself.
Thank you, Anabela. Good morning, good afternoon, everyone. My name is Wadhah Hubaishi, currently Deputy Director for Operations for IRC Syria. I am a supply chain professional in my experience for the past 17 years, split across both the commercial, private supply chain and the humanitarian relief operations. I've worked in Yemen and Syria. My field of experience is focused on emergency relief within the context of emergency. I have certification in humanitarian supply chain management and a master's in development studies from the UK. Thank you.
Thank you, Wadhah. And our next speaker is Danielle Jurman. Thank you so much for joining us also, Danielle, with all your experience in emergencies. So please introduce yourself.
Thank you so much, and apologies about I'm having some camera issues, so I won't be able to turn that on today. But my name is Dani Jurman. I work for UNFPA's Humanitarian Response Division based in Geneva. I'm a humanitarian medical logistician, and I work to basically support all of our country offices operating in humanitarian contexts and all aspects of end-to-end logistics and supply chain management, particularly in the period of emergency response in the beginning days of the crisis. I've been supporting a number of different responses, and I have a master's in reproductive and sexual health from London School of Hygiene and Tropical Medicine, and I have a certificate of humanitarian medical logistics. Thanks.
Thank you, Danielle. And we are also joined by the BHA Capacity Building Program Leader, Nadia Olson. Thank you for joining us, Nadia. It's always great to have you with us. I will go ahead and do some housekeeping reminders. Next slide, please. First of all, we want you to use the chat to introduce yourselves, and the chat for Q&A. All your questions and comments are very important. We don't want to miss any of them. So please, as our session moves on, if you have any question to one of the speakers or in general, please say the question and whom are you asking the question. If it's general, just post your questions and we are going to monitor each of them. We're also going to have, as always, a Q&A session to address most of the questions. Hopefully we will have time. Next slide, please. As always, we would like to thank the USAID Bureau for Humanitarian Assistance. This activity, these webinars are thanks to the support of the USAID BHA capacity building program. And we have several objectives that altogether support the objective of improving capacity in pharmaceutical management in humanitarian and emergency settings. We develop curriculum, we conduct trainings, both in-person and blended learning courses. We share learnings through our community of practice, and we also support partners in targeted areas of supply chain management, their policies and procedures. Next slide, please. As many of you that have participated in our previous webinars, this is part of what we call Education Series. And for this year, this is the 5th session. And a reminder that if you have attended 4 or more, you will get a certificate of attendance at the end of the year. So we have one more webinar to go, and stay tuned to get your certificate. Next slide, please. We're covering very important objectives today related to the topic of forecasting and quantification. First of all, we are going to have an overview of the forecasting and quantification processes, data preparedness in emergency settings, what happens when you don't have all the data that you need to make your scenarios and develop your supply planning. Second, we are also going to review forecasting and quantification challenges and solutions, especially in emergency settings. Wadhah and Laila, our speakers, will talk about it as well. And lastly, we will learn from examples of how to transition from health kits to individual items. We know that that is a hot topic for all of us. Having examples of how to do it effectively impacts on reducing waste and managing your supply chain overall in an effective manner. Next slide, please. Sorry about the noise. So, okay, so without further ado, I'm going to pass the floor to Dani. Go ahead, Dani.
Thanks. Next slide. So basically what I will just quickly go through during the course of this more introduction presentation is a little bit of background around when we talk about humanitarian crisis, what are we really talking about and how that then is impacting our ability to forecast and quantify for pharmaceuticals and medical devices. And I'll also talk a little bit about how we do that in the onset of an emergency. But just to kind of kick it off, I think this is not new information for most people on the call, but the number of people affected by humanitarian crisis globally is increasing. The number of humanitarian emergencies that we respond to on a regular basis is increasing. And these crises range from sudden onset, more acute emergencies to ones that have been going on for long periods of time, where there might be, short changes or increases in the impact of the crisis. And on top of that, of course, you have the natural disaster impacts, cyclical natural disasters, climate change induced disasters, and all of this is leading to a massive increase in humanitarian aid need. And so as a result, a lot of these areas that we talk about here are really, really important to think about. Not only how are we doing this kind of forecasting and quantification in the early days of a crisis, but then how do we move away from more of these push supply chain models? Because the reality is that crises don't start and end in 3 months. And so thinking about how we can really sustainably and effectively meeting the needs of affected communities is really important. Next slide, please. And so, yeah, here I will go into it now. You can go to the next slide. So there's a lot of different people that might be attending the webinar. So just to kind of make sure that we're all on the same page in terms of the terminology and what we mean when we say humanitarian crisis. So for those of you who work in humanitarian response, the diagram on the left is not something that's particularly new. But basically, you have the kind of pre-crisis phase, which is really that preparedness. So how are we working to mitigate and improve our ability to respond in the event that the crisis actually occurs? After the event happens itself, this is what we refer to as the acute crisis response phase, or more the emergency phase. And then when we think about how it can evolve from there, it can either evolve into more of a protracted or long-term humanitarian crisis, or it can move to a recovery. When we talk about supply chain and logistics, let's say activities, interventions, and needs, we refer to both of these periods of time as the post-acute response period, because a lot of the interventions are actually the same. Next slide. So in an emergency, there's a few goals that we have when it comes to the supply chain. The first one is to deliver life-saving supplies fast, to be able to ensure the availability of supplies to meet an unknown and changing demand, to ensure the ability to operate and actually deliver items despite complex and restrictive logistics environments, and at the same time thinking about how we're minimizing potential negative impact on people, animals, or the environment that we're working in. Next slide. So in a humanitarian crisis, supply chains are disrupted and there's a huge increase in logistics bottlenecks, while at the same time needs are skyrocketing for intervention. Right. And so what does this look like, and how is this linking in some ways with supply chain? So when you have a sudden and often unpredicted increase in needs, this can lead to really, demand uncertainty, right? We don't actually know in a specific level the demands of the affected community, because we don't actually know next week or the week after the totality of people that might be impacted and what those demographics look like. At the same time, you have a decreased capacity of the national system, leading to both demand and supply uncertainty in different ways, right? This can be a disruption to the local market capacity, damage to health facility infrastructure, or disruption to pre-existing medical supply chains. You also have a decreased capacity often from government ministries, or maybe a change in government, or the multiple governments that come up, or non-state armed actors who are administrating different parts of a state. You also have a huge influx of humanitarian actors. So you have a lot of people trying to deliver in coordination without being duplicative, also linking in that demand uncertainty, right? How much of that demand do we need to be able to fulfill as one organization? You have a decreased availability of logistics service providers and essential health facility staff. This could be, private sector infrastructure damaged or interrupted. You can have a lack of willingness of certain staff to move to specific areas. And you also have staff within the health facilities themselves who might be impacted. You also have this increase in logistics bottlenecks, and this is really linked to supply uncertainty. When we're talking about forecasting and quantification, the ability to take into consideration the distribution lead times and challenges that might come up in that is really key. And so there's just a number of different ways here that crises can impact the actual logistics infrastructure within the country, causing uncertainty in our ability to actually supply facilities. And then finally, we also have a change often in rules and regulations that can lead to supply uncertainty, right? There might be new laws that come up of restricting certain items or adding more importation requirements. And then on the bottom right-hand side, I also wanted to highlight that while all of this is going on in the operating environment, internally within humanitarian, let's say, programming or response organizations, you might also have, an overall lack of internal experts who can forecast and quantify. You might have questions when you're doing procurement around aspects around quality and how you can maintain the quality and distribution. Overall, within the humanitarian sector, there's a lack of prioritization of medical logistics in general, and how that gets addressed is really inconsistent. And then, of course, there's financial resource gaps, which means that even if we know the demand and even if we want to supply and can supply, we might not be able to actually meet that demand. And then, of course, there's data gaps, which we'll go into a little bit more. Next slide, please. So overall, the goal in a humanitarian context is that in coordination with other humanitarian health and logistics actors, we need to overcome the disruptions and conduct as much as possible an informed push of supplies to the last mile using kits, until enough data and stability allows us to transition to a pull supply chain system, which allows for this more contextualized, demand-driven, cheaper, and more sustainable supply chain. Next slide, please. So thinking about some of the factors that can affect quantification, this idea around using a push supply chain model involves a lot of assumptions around what you're trying to provide to the community, and inherently it will be imperfect, right? And so thinking about how much data you have to do more of an informed push as opposed to just a kind of blanket push model of supplies will depend on the context that you're in. As well, depending on your context, you might be in a centralized health system or a decentralized health system. And those have different challenges, right? In a centralized health system where you have a central medical store and the central government has quite an oversight around demand or supply availability, or should have, let's say, of course, that's imperfect. It's a very different context than when you're working in a health system where that's done at the district or state level, and there might not be that centralized visibility or centralized stock management. It also matters how much you know about pre-crisis availability of supplies. So what kind of data do you have from before the crisis actually happened? Depending on the context, you might have a lot or a little. And then how much do you know about pre-crisis needs, right? What does the demand of services look like among the affected community? Were those supplies actually meeting the demand of those services even before the emergency? You then also have to think about how the crisis itself might have impacted those demand patterns, right? Increased aspects for us as UNFPA related to clinical issues and safe delivery. You might have increased GBV needs for CMR services and other types of, you might have an increased need for trauma supplies, right? So it really depends on how the crisis has impacted those demand patterns. You also have to think about, as I said earlier, how the medical supply chain has been actually impacted, right? Not every crisis is the same. Election-induced violence in one part of the world versus a natural disaster in another, versus a localized conflict or a full-blown conflict within an entire country will have different impacts on the medical supply chain, right? So is there actually a need that we need to fulfill? And then will the national health system be able to equitably prioritize distribution based on needs? Right, humanitarian principles, as humanitarian actors, we need to ensure that all are able to receive the aid that they require. Whereas when you're thinking about operating in a conflict environment where perhaps the national government is a party to the conflict, the consideration of will the national government be able to actually equitably distribute based on those needs? And then finally, what are the different sources of supplies coming in? Right, as I mentioned, you have a huge amount of humanitarian actors. You've got the pre-existing national government supply chain. You've got private sector supply chain. And so in order to actually understand the demand that you need to fulfill as an organization, you also have to think about what other sources of commodities that are coming in. And then finally, this is all underpinned by this ability to actually receive, manage, and dispatch supplies when it comes to it. Next slide. So how do we actually forecast in an emergency? So internally within an organization like UNFPA, the idea is that we have a humanitarian response plan, which defines what do we actually want to achieve programmatically. And based on that, we are able to develop a supply plan, right? So what do we actually need from a supply perspective in order to fulfill our objectives of our humanitarian response plan, which should hopefully be developed in coordination with other actors. When thinking about how we then look at that across the sector for reproductive health, we need to think about, okay, what is the total amount of supplies that might be needed for the affected community to fulfill life-saving services? And then we compare what others are able to procure and import, what UNFPA can bring in, and then also defining what is that gap that we need to fill. Next slide. So data collection in these emergency contexts is really difficult. Because of access constraints. You might have a lack of capacity at service delivery points. You might not have internet up and running for maybe an ELMIS system that might have been functioning before. And there's a risk that as a result, data is not available. It might not even be collected consumption data. It's not reliable because of the changes of the crisis or different previous stockouts, which might be skewing the reporting around consumption. And it might not be accessible, right? The government might not want to share it. The internet might be down. We might not have physical access to places to collect that information. Next slide. And so as a result, many humanitarian organizations procure and distribute medical kits, which are basically pre-designed kits based on global level assumptions, which help us to kind of overcome that bottleneck around forecasting and quantification. And many of these kits are based on basically very kind of structured information where when you actually want to procure the kit, the only thing you need to really know is the total number of targeted population that you're trying to reach, the number of each type of health facility that you have at different levels. And if you have some pre-crisis information which may be available, you can even further contextualize that order. But the reality is when you think about doing this kind of quantification, you need to think around, okay, how do we then apply that within the context that we're in, right? So linking it to those questions that we raised earlier, has the supply chain actually been disrupted? Can the population actually access the facilities that we're trying to distribute supplies to? Next slide. So for UNFPA, we have the Interagency Emergency Reproductive Health Kits, which are kits that we host on behalf of the interagency sector. So it's not just for UNFPA, but for all actors delivering SRH services. And this is just a quick screenshot around what the kits are. I believe that the manual will be shared for anyone who's interested. Next slide. And these kits, as I said, are based on a series of assumptions, right? Based on a standard population composition, WHO treatment protocols. We look at things like contraceptive prevalence rates in the average low and middle income fragile context. And we develop a standard population with standard needs based on those assumptions, right? And so we also have to look at, when we design these kits, we need to look at these different indicators through the lens of fragile states. So for example, we have included misoprostol for those of you who do SRH for second-line treatment of postpartum hemorrhage, because the first-line treatment is oxytocin, which requires cold chain. And we don't often have cold chain, right? And so these are things that we also need to consider when we're determining how much to send. Next slide. We do have a calculator, which we have also shared and you'll be receiving, which is useful when doing this kind of calculation around how much kits you actually need. Next slide. And within the calculator, you can see it's an interactive Excel-based tool where you can put in the targeted population figures, the number and level of each type of health facility on the left-hand side. And the second prompt will then ask you a number of questions which you may or may not have information of, which can help you further to contextualize that order based on pre-crisis information. Next slide. And as a result, you'll get an order output. And more often than not, this order output will be very, very high, right? Because the reality is that no single organization is trying to meet these needs alone. And so the goal is that where it exists, partners should be working within the SRH working group for a divide and conquer approach, basically. Who is procuring what and where, and how are we taking that into consideration based on the total needs that there are from the output of this tool. Next slide. And so before I hand it over to Laila, I think this is all well and good when it comes to the early days of an emergency, because the goal is really to just push supplies there to meet that life-saving need. But really, as soon as possible, we need to think about how we can further contextualize those supplies to actually meet the demands of the population based on their really specific consumption and service patterns that they have, right? And so in order to do that, we need to stop providing kits and start procuring individual items using that full supply chain system based on demand. However, the type of data that you need to do this and the collection of that in emergencies can be really challenging. And for UNFPA and other partners, we have to think about how we can be creative to either get more of that data or collect proxy data, which might tell us enough information where we can make some assumptions in order to help us to at least have a more contextualized order over time, right? And so there's things around remote data collection, how we can use third-party monitors, how we can work together where one organization is going to a specific region to collect data, we ask them to help us out, right? You can think about more traditional things like paper-based reporting where, health workers take photos of the reports once a month and send them via WhatsApp, right? And so thinking about how we collect this data is really important. But overall, one of the big lessons is that it's better to collect less data quantity, but higher quality and more consistently, and use that to make strong assumptions. But I will now pass it over to Laila to talk a little bit about the quantification process.
Thank you so much, Dani. Next slide. Maybe it'll be good for us to just review what it is we're talking about when we say quantification. So quantification usually has a two-step process of determining what your demand is, and then planning for when and how much to be able to supply that demand or supply planning. But the most important piece of that is to prepare for your activity of forecasting and supply planning by doing the preparation phase. And why would you want to do something like this? So for why do we determine our demand and supply planning? To the next slide. There's many different reasons. That could be for advocacy purposes. It could be for procurement purposes, most often for distributing the right amount to different sites. If you have a new program or an expanding program, and we're talking about humanitarian now, so a new crisis, then you really do need to know and understand what it is that kind of services and morbidities and will be catered for so that you can supply the products that are needed for that. For budgeting, and also if you're doing this properly, it does assist with ensuring product quality because you do know then what it is that your system needs and have better chance and time to be able to plan for that better. Next slide. So when I spoke about preparation, I think one of the most important steps, and this has come up in some other conversations on IAPHL as well recently, when we talked about the blood work recently, was to make sure that you understand your program, understand the context of what it is you're trying to do. And that second point there, defining your scope and your purpose. We saw all those different reasons for quantification on the previous slide. What is the reason for the activity that you're doing now? Is it for procurement? Is it for budgeting? Is it for a new program? And understanding what the purpose for your quantification activity is will help you then proceed more efficiently into the next steps, and be able to collect the right data for that activity. If it's cost information, then you could do, look at only total costs, for example. But if it's procurement information, then you need to have more unit cost information. So when we want to collect the information and prepare for this next step of demand forecasting is these questions of who, what, where, when, how, and why. So, who are your stakeholders? Who are you providing the products to? Who are the users of the products? What kind of services will be provided? What kind of products are you responsible for procuring, perhaps? Maybe not everything. Maybe there's certain sector that you want to cater to because you have limited resources. Where are the products going to be used and going to? Are there some certain capacity limitations? Is there a time frame, both in terms of how you have your data collected and how far into the future and what period of time are you forecasting for? So weekly, monthly, annually, etc. Once we have understood our scope and purpose, and we've collected enough information, we can go back to forecasting our demand, which is the next slide. And you might come back to this as you start to do forecasting. You might realize you need more information. But forecasting, again, is to estimate the quantities of products that will be dispensed either to users, clients, or used by the health program over a specific period of time in the future. So we're going to organize and analyze and adjust our data, and adjusting it for things like, if you're missing a month's report, that doesn't mean that nothing was used then. It just means that you don't know how much was used. So you need to estimate what would have been used or could have been used had the product been in stock. Building forecasting assumptions. If you don't have good data, then there's a lot more assumptions that are needed to be made. Then you calculate for each of those products. And hopefully you're able to do multiple different forecasts, which is always the preferred process, so that you can maybe figure out if you only do one, you don't know if it's too high or too low or if it's accurate. But if you do multiple ones, then you can see where each one falls and how good the quality of the data for each was, and maybe perhaps where you might have made an error, either mathematically or an assumption, to be able to choose what you feel with your group of stakeholders, what could be the correct forecast. Next slide. And let's just review a little bit what the different kinds of forecasts are. And three specific ones that we refer to here will be in the circles: the demographic forecast, the services forecast, and the consumption forecast. The demographics and services forecasts rely on understanding the population and the context for services given, or the group of people that are involved in the health system. And they take those figures of people with certain morbidities or treatment requirements or services being given and apply a standard treatment guidance to derive at a product. And so there is an error introduced in assuming that everyone will follow the standard treatment guidance, or that it's given, or that everyone will have access to it. And so you do need to make some assumptions around that. They're both projecting into the future. They're saying this is how many people we think will be needed, or this is how many services based on historic information will be coming in to get products. Consumption information and services information also share something together, where they're reflecting on what the past capacity of the system was to provide something, so that if you have so many doctors and so many nurses, only this much services could have been provided, or only this much product was given out. And it's a better measurement of what the capacity of the system was had everything been in stock for consumption data. Consumption forecast, though, is the only one that is a reflection of the number of products that are being used. So it's usually the gold standard if there's good quality data available and there haven't been lots of stockouts, and you have, again, accurate quality data. It is a reflection of this is what was used, and so it's a more accurate, expectation for what the future consumption of products will be. Next slide. Once we've determined that and we've reconciled or combined some of those forecasts into the one that we believe is a more accurate reflection of the future, we have to supply the system. And supplying the system will require you to understand the system in which you're working in, how many different levels are there, how much is your lead time, how much safety stock you want to carry, how much budget you have, and how much inventory is being held, what the expirations for products will be, so that you know how much to order and when to order them, so that you can supply for the demand. If you have tons of inventory in stock and they're not going to expire, the demand will still be able to be met. It just means that you don't need to order it at this time. So supply planning is applying that forecasted requirement to your current system to determine when best to receive products, to assure that there's adequate levels of stock in the system, and also to prevent any overstocking or understocking. Next slide. And I'm going to hand over to Danny for this one before we talk about what's going on with the examples that we want to share with you today.
Yeah, sure. And so as Laila said, both of the examples that will be shared today are a byproduct of a pilot project that UNFPA initiated with the support of JSI, which really wanted to look at how we can really...
Annie, did we lose you?
Can you hear me?
Yes, now we can.
Sorry. So as I was saying, UNFPA, both of the pilots that will be talked about today were pilots that were initiated by UNFPA together with the support of JSI to really help provide some concrete guidance and support to country offices who want to look at moving away from kits to bulk procurement of items based on demand, considering the context that we are operating, which remained, more protracted or long-term.
We lose you again? Okay. I will assume that I can move on and we can talk about the two different experiences. So thinking about, again, Danny sharing the reason for why UNFPA initiated this, moving away from kits and figuring out how many bulk items individually needed to be procured. So next slide. Me and Danny did the first of these pilots in 2018. Now it seems like so long ago. It was after about 11 months or so of the crisis where the Rohingya population was crossing the river into Cox's Bazar in Bangladesh. They had been procuring kits for several months by then and supplying their implementing partners in the camps and the surrounding areas. And we wanted to see how we could go about transitioning them away from the kit system. And so the next slide, and the first thing I spoke about was, so this was it. So the scope was, and make some recommendations. So anything that we saw that could be strengthened was also added while we were there to build any capacity for the staff so that they can continue to do this work in the future and then help them develop a forecast and a plan for those individual bulk products to be procured. Next slide. First thing we did was map the system. So I needed to understand the context of the situation and how complicated it was, who was doing the procurement. The different colored lines, you don't really need to understand this map, is just to understand the flow of the products, the flow of the information, and the flow of the goods and funding. And just understand what kits were being procured, how many different individual items were being procured outside the system, if it was private or public sector, and to what extent information we could gather, and what kind of information that they had. So next slide. They had some really strong systems. Staff was really reliable. There was excellent paper recording at the service facility points. There was some really good service data. Warehouses were well kept. There was some Excel spreadsheets of which kits were being received and distributed out. But again, there was some missing information, and there was some standard operating procedures, essential medicines list from this region in Bangladesh, and they were being followed by the providers in the system. Next slide. However, some of the challenges were that wasn't really clear what products and services were being provided. There wasn't, because this was an emergency setting, again, it wasn't a design system, so there were really not min and maxes or inventory management protocols or resupply schedules being followed and were being created organically. But there was a process in place to do that, and a recognition that that was important. The quality of the data, again, lacking. So there was a lot of naive forecasts, which is just using the historic, I think we used 5 last time, so let's just use 5 again. And the items that were being provided in the kits didn't necessarily meet all the needs, and that's just how it is for any setting. One clear example was glove sizes. Our average global glove sizes, but in Bangladesh, majority needed smaller glove sizes. So next slide. What we did, and we can skip this one just for time purposes. I think it might be easier to move on. The quality of data. Next slide. So we did try to do some proxy consumption, which is looking at what was being issued out rather than what was being used. And we captured about 60% of that, so we could extrapolate. We were able to do some of the demographics, and assuming based on the kits guidance system and global averages of what needs would be for a certain group of populations, we moved backwards to determine what products would be needed. And there were some service data being gathered on how many different, labor and delivery and different types of basic services that UNFPA and others were interested in collecting, but not all services were being collected. Next slide. So you can see this is just a sample of what the results showed us between the different forecasts. Some of them were varied from really high. You see the iron levels from, you know, what partners were issuing out versus what UNFPA was providing is very different. So they're getting that product from the local market. In the others, you can see with the contraceptive methods, you have, you know, the services saying there was a need for this level of the kit 2A, but UNFPA again was only providing a portion of it. So this was reviewed in context with the key stakeholders and the quality of the data to determine what we wanted to assume the future would be. Next slide. So we left them with a bunch of next steps to determine what UNFPA wanted to be responsible for in terms of procuring. There was a lot of products that the implementing partners were getting from the local market, which wasn't necessarily something UNFPA wanted to cater for. To come up with the inventory protocols, to collect several more months of issue data from the partners, determine a way to come up with an information system to collect this information better in the future, and inform all of the parties what the next steps would be and what would be procured and available through UNFPA, figure out a supply plan, and then begin the transition. So not transition until all of these different activities were done. Next step. Next slide. So 1 year post-visit, we did inquire as to how things were going. UNFPA had developed an e-stock information system. They had recruited more paramedics to improve the supply data recording at several facilities so that there's better information. They had not yet transitioned. They had enough kits that they didn't need to do that quite yet. And they were able to allocate a certain level of budget for these activities. And we did do an assessment of what our absolute error rates were using one measure of accuracy. And we were not too far off, which is good for in our sector to be around 23%. Next slide. We're going to go to Wadhah, and he can talk to you about the second exercise and another one of his experiences.
Thank you, Laila, and Danny, for introducing this second case study. Going to talk about the quantification exercise done for UNFPA in Yemen. Next slides, please. So as you know, as mentioned by Danny, UNFPA has 12 kits, part of the IARH reproductive health. The purpose of this exercise basically was to assess the viability, first to provide supply planning for the future, and additionally also to make recommendations how to improve the quality, the availability of such commodities. They have a lot of positives, but also they're expensive. Not all items are fast moving, so the purpose was to have a plan about how to make this better, especially within the context of Yemen, and to look into pre-positioning of these items as the shifting front lines due to the Yemen protracted conflict was the case. Next step. Again, it's very important first to do supply chain mapping. It gives us understanding of the flow of commodities into the country and also the complexities related to it. This one in front of you represents Yemen. Due to the war, Yemen has basically been split into two areas of control. And that is not only geographic, it also dictated the stance that such governments have towards reproductive health. So in the case of Yemen, 90% of reproductive health commodities came from UNFPA. The forecast was done using the available information at both government authorities. There was a lot of logistical bottlenecks. This can be figured out from the supply chain mapping, such as these two spheres of controls. They don't talk with one another. That creates a bit of difficulty when importing or transporting these items from south of Yemen, where these commodities get into, and move to the north. The kits are given to the service delivery points who distribute it either to get their quota from the Ministry of Health, or sometimes the Ministry of Health pushes these items near expiry to the health facilities. Next step. Next slide, please. So what are the challenges? Laila talked about this a little bit. The unavailability of the data. This is the first kind of obstacle that face you when trying to get more accurate information. An example is the unmet demand. Just because a health facility is because it's stocked out, that doesn't mean it has delivered all the demand. There could be a demand that is not captured, and beneficiaries, when they come 2-3 times to the health facility, they don't find what they need. They already stop coming. Also, but we've noticed that beneficiaries come, for example, for reproductive health commodities when the health facility provides primary health care. It's an added benefit. If the health facility loses primary health services or there's interruption, beneficiaries, they don't have the same incentive to go and have there's certainly complementarity of services here. Also, reproductive health tends to take a second or a backstage during conflict because people look for primary health care and survival. That's certainly something that we have witnessed. Last point about the challenges is that the government authorities, somehow due to social, religious reasons, they become anti-family planning. This creates difficulty. It is important to talk about how it is necessary to get government buy-in to conduct this quantification. If the government is not happy about reproductive health, that will make your life more difficult. Next slide. So there's a lot on this slide, but I'm going to go through them fast. So what do you do? If you don't find the gold standard, the consumption data, you move to the next the best thing, which is the dispatch. In this case, because 90% of the items came from UNFPA, it was easy to get everything that got into country. Then with that kind of information, you formulate one of your forecasts, then you have the other two of the demographic and the services, and you extrapolate between all of them. And it's important to do as much work as possible before deployment and assess everything that is in the supply chain, whatever is incoming, outgoing, whatever you have stock in hand or in the pipeline. And then because the less reliable the information, you have to make more assumptions, and you want to reduce making assumptions. My observation working in Yemen, that the first victim during conflict is, power. You lose power, it becomes prohibitively expensive to operate, generators. There's shortage of fuel, and that makes for an interesting point where the forecast, for example, for oxytocin, showed us that the consumption is way more than what the demographic should use. And the result was that is because there is no cold chain, so oxytocin lost its efficacy, which made midwives, naturally by experience give more dosage. This is the kind of information or learnings you will take from this kind of comparison or triangulation of the forecast. Another point was that the kits are ordered whole. The shelf life of the kit is labeled as the shortest life, shelf life of its commodities. Technically, this means a lot of components are expired because the whole kit expired, but not all of them are actually expired. That's the way that the kits are designed, right? But also there's some of the contents are problematic. When you talk about condoms, IUDs, kit 3 for rape is a taboo issue. Furthermore, kits that has ketamine can be held because it's a controlled substance. It's also, desirable by armed groups. This means if one component in the kits is problematic, the whole kits gets designed. This is more incentive to go into bulk, to push whatever is fast moving more, and then hold, not get these kits held. But also it's very important to sit with the actual health facility staff, to speak with them, to learn about the practices they do in the field, rather than just making decisions away from them. You can learn a lot about it, about how the kit is used, how it is, I've been told that there's a lot of consumables, but the more pharma is required, the surgical kit is very popular and very useful as well. So make a point to speak with the health facility staff. Everyone has or knows a piece of the puzzle that will be very helpful to your exercise. Next slide. I'm going to talk briefly about a different kind of setting now, which is the emergency response. As you know, February 6th, there was an earthquake that happened in Turkey and Syria. 50,000 people died. It was a 7.8 magnitude earthquake on the Richter scale. And there was some lessons learned that I wanted to share with you about it. When this happens, you as an organization will be hit as well. Your capacity to respond is hit. That means supply chain disruptions across the whole port, logistical bottlenecks, ports closing, roads are damaged. And also, when you try to quantify, you will realize that the extent of damage is not yet known fully. The number of casualties will only become clearer with time. This means every day matters, and this means you cannot wait for a long time before you start responding to this. And this requires us to do a push by going into a no-regret procurement at the beginning to ensure that you get the commodities inside. And one thing I found out, just because you have a piece of paper, an agreement with the vendor, during the earthquake, during emergency, there will be a lot of competition over resources. That doesn't mean you will get whatever you want. That's why it's important to move fast. But also, as the picture gets clearer, you get more feedback from the government authorities, from partners who are working inside. They will give you a better estimate so that you can start shifting from this push to a pull system. Next slides. This one is over to Danny.
Thanks. Next slide, please. So overall, there was a lot of lessons that we've learned in the 3 pilots. So you heard about Cox's Bazar in Yemen. We also did the same exercise in Iraq. Basically from these kinds of, from these pilots, we learned a few things. There's a lot of common challenges that we are observing. The first one being the lack of long-term funding required. And so in humanitarian response environments, we're often working with 1 year or less funding cycles, which makes it very difficult to maintain a constant flow of commodities through bulk procurement, particularly when you talk about medical items that can have, 4 to 6 months of a manufacturing lead time. There's also an overall lack of data availability, whether we're talking about the consumption data, which we've heard really a lot about, but even from services data, right? How are we collecting this data across the sector? It could be that we're collecting number of family planning consultations, right, as a common indicator, which doesn't really tell us much about supplies. And then even demographic data, it might be often outdated or not considering the impact of the emergency. In the case of Cox's Bazar, the Rohingya were not included in the pre-existing Myanmar census because of political reasons, which made it really difficult to get accurate demographic data. There's also a significant need for capacity building, both around how we're doing inventory management and data collection, but also having staff who can regularly update and maintain these kinds of systems around forecasting and quantification. As well, the infrastructure to manage bulk items from a logistics perspective is significantly different than kits, right? Managing 12 kits throughout your system, both the actual physical management in the warehouse and from an inventory perspective, is very different than managing, 490 items, which is how much approximately we have in total in our kits, right? The dynamic of many partners bringing in supplies and distributing to the same locations means that in order to do this exercise most effectively, it needs to be done together with other partners. Most of the items that we provide in reproductive health are not unique to reproductive health. Gloves are gloves, right? They're also used in trauma. They're also used in primary health care. How we work in centralized and decentralized health systems also needs to be different. As well, the lack of capacity for pharmacy data collection and management at the particularly health facility level was really high. This idea around, you're not looking at managing a kit anymore at the facility level. It moves to that individual item procurement, and how that's recorded can be really inconsistent. And then finally, there's this multiple parallel supply chain issue where they're talking about humanitarian organizations, private sector, and the national government, which can cause a lot of challenges, particularly in contexts where the government may or may not be willing to serve a specific area that we're targeting as the humanitarian sector. Next slide. And as a result, there's also a few lessons that we've had in terms of how you can go about doing this kind of exercise. The reality is that this exercise requires time investment from both program and operation staff. So the people defining the programmatic needs and working with the service points, and the people doing the procurement and logistics operations. that first step of mapping the goods flow is really critical, not just for the sake of the exercise, but to really understand things that you might not know going into it. The importance of really speaking to the service delivery points, and not necessarily just the hospital directors, but going to, for us, the maternity wards, and speaking to the head of maternity, speaking to the nurses and midwives who are actually using the commodities and doing the dispatch, can provide you a lot more insights, and is really critical. It's really important to assess the logistics capacity around the supply chain. You can have a perfect forecasting and quantification exercise, but if you can't actually do your supply plan because you don't know the lead times, or if you don't actually have the ability to actually dispatch those commodities to the locations, it's really going to be very difficult to make that transition to individual items, because the reality is that kits are a lot more logistically easier to manage than bulk items. You finally also have to assess where your data is limited, right? So this is very different in a context where an LMIS system exists versus where it doesn't. But the reality is that we're never going to have perfect data, especially in an emergency context, right? And so as a result, you have to be comfortable with the assumptions you make and review them over time. And then the data quality is critical, right? Question, are the stock on hand figures at service delivery points correct? Right? When you're at the service delivery points, looking at the records that they have versus the stocks that are on the shelves, to actually make sure that information is accurate. As I said, using assumptions where data is limited may be the only way forward. And then finally, consider how to systematize data collection where access or internet is limited, right? It's this idea that we always need this perfect, really advanced system in order to actually collect this data, when in reality, there's a lot of ways that we can find innovative solutions where we don't have physical access or where the internet is not consistent, to be able to collect at least, a basic amount of good quality data consistently. Next slide. And I think this is Laila, yes?
Hi, sorry. So thank you so much, Danny. We're reaching the end, 2 minutes. Hopefully we've answered all of your questions. And as you can see, good supply chain practices can be adapted in all response settings. We can introduce a selection process, so determining what kind of goods you want to have in your system, again, increasing the data visibility. We know that this is a challenge, but any steps towards that will be better than anything that wasn't there before. Designing a industry standard of a max-min inventory protocol will help you with the supply planning process and understanding how much inventory you need to hold. And then developing guidance and capacity regarding any pre-positioning that can be done, and any best practices across supply chain management that could be done to bridge that emergency response to an institutionalized national system. Thank you. I think we need to maybe wrap up, Annabelle. That's okay. Thank you.
Yes. Okay, so thank you so much for all your questions. We have answered many of them, as you will see in the Q&A box, but we also have somebody that had raised hand. Shafi, if you still have a question or comment to make, we have a few minutes if you would like to do that. Otherwise, is there
Annabelle, can I just answer that one question about the carbetocin, just because it's a little bit difficult to answer in writing?
Yes, please go ahead.
Great. So there was one question around, has the inclusion of carbetocin, which doesn't require cold chain to replace oxytocin, been considered for UNFPA? And I think this is really, really important. And so I wanted to take the time to say it. Heat stable carbetocin is not a replacement for oxytocin. The clinical indications are different. It only serves, I believe, 2 of the signal functions which oxytocin can be used for. As a result, misoprostol is still the second-line treatment for postpartum hemorrhage. We are looking into the rollout of heat stable carbetocin in 2 contexts right now that are humanitarian, to try to think about how we can safely include this item in our kits moving forward. But the dynamic is that there's a lot of misunderstanding around when you use heat stable carbetocin versus oxytocin. And so by including these items in the kits, there is a risk that the product gets used more often than not in a way that it shouldn't be. And so that's what we're trying to do right now, is really collect that data to make sure that every item we include in our kits not only meets the need of the community, but does not actually have an unintended negative impact on the communities that we're serving. I hope that answered the question.
Thank you. Thank you, Dani. I think that we have answered, as I said, most of the questions. There is one from Hiba Ahmed. The pipeline waiting with very slow request steps in UNFPA cost us a lot in Sudan 2023 conflicts due to political instability. I understand this is a comment, but I don't know if any of the speakers would like to.
I think it raises a really good point, where I was trying to emphasize that you can do the perfect forecasting and quantification, but when it comes down to it, the logistics infrastructure and the ability to actually distribute the commodities to the end user is really, really critical. And in Sudan, you know, we're still supplying supplies to Sudan as we speak now. Recently, it was declared a scale up last week, I believe. But even from the beginning of the crisis, and the reality is that the distribution within country is incredibly complicated because of the political instability. And this is something that all the actors are trying to work on together. And so this is why I just wanted to take the moment to emphasize that we should not separate the conversation around the forecasting and quantification in emergency to the medical logistics infrastructure to actually distribute the goods at the right quality at the right time. Thanks.
Yes, thank you for those reminders and highlights, Dani. That's very important. And I think that we have covered many of the questions. There was one general about, please help me to deeply understand the indicators that determines emergency settings. I think that we can send some materials to answer that, unless any of the speakers would like to guide us. John Sandy is the one giving that comment. And one last one, we have a few minutes. We had planned for this session to have a few minutes more. Breda Gahan, she says, agree, Mulenga, Laila supporting on this, but demand on HW and population sites ongoing is a challenge. More public education globally necessary.
I think this was in reference to injectable products being preferred by clients coming in, and what could be done to dissuade that, perhaps for clinical guidance.
Yes. All right. So I think that we're moving to the end. We just want to show, I think the presentation is not up, but I just wanted to thank you so much for your participation, for the many questions. We, as always, we send the webinar slides with resources in the last slide. So wait for our email to follow up and with all the answers to your questions. So thank you again to Laila, Dani, and Wadhah, and everybody supporting this webinar. Thank you so much, and thank you for your participation. Stay tuned. We're going to send you invitations for our next education series event of the year. Okay? So have a great day and afternoon.
Thank you. Bye-bye.
Bye-bye.
Thank you all. Bye-bye.